Welcome, everybody. Welcome, family, like we call each other. And thank you for coming and joining us of Doc Talks with Dr. Forrest Tennant and friends. Our special guest tonight is Denise Lewis, and we're really excited to have her with us. And we do extend a warm welcome to you, Denise. We're glad you're here. Thanks for being part of the family. Dr. Tennant, I know you have a full boat ahead of us, so I will hush and let you go ahead and take over. Thanks so much.
Thank you very much, Jamie. It's great to be here and see all of you. We've got a very, very busy schedule tonight. As always, it seems like each week we have more things we want to talk about, more issues we want to bring up. But I'm going to get into the educational part of this very quickly and get it, I don't want to say get it over with, but get on to something that is the first of us several sessions. I know that some of you are aware that I and my foundation have been doing research on the Epstein-Barr virus for the last few years. I'm pleased tonight, or I guess in some ways unpleased, because a lot of it's very unpleasant news, to talk about what this virus is and why it is now a major factor in the diagnosis and treatment of chronic and intractable pain patients. Now, this is quite a surprise to all of us. First off, I'm going to give you a little history of my own about viruses and about intractable pain. In the 1970s, some of the very first people that I treated in our intractable pain clinic were people who had had polio. Now, they were still alive. They'd caught polio in the 40s and 50s. And so they were still alive, but a lot of them, interestingly enough, suffered from intractable pain due to leg and foot neuropathies. That was where their pain was. And of course, I treated them, and we didn't know a lot about it at that time, except to relieve their pain. And incidentally, back in those years, we didn't have opioid restrictions. We didn't have all the people telling us we can't treat pain. So whatever we needed, we got for people. So that's the first thing you should know. But I remember something very vividly about those post-polio patients. I'd come to the clinic and they'd start telling me stories about how the pain would have exacerbations. And with those exacerbations, they had some fevers and they had sweating. And I remember going home and telling my wife, Miriam, one night, you know, Miriam, I'm beginning to wonder that maybe that polio didn't completely go away. And in some ways, I was right. Now, in those days, we didn't have blood tests for polio or for viruses. It was a new thing. The other thing that happened during the 1970s and 80s is long past. Just like polio is gone, but another thing that's long past is the really severe cases of what we call post-herpetic neuralgia. Now, people who have had chickenpox are subject to later in life developing herpes zoster, better known as shingles. Now, except in rare cases, shingles is nothing to be too concerned about it today. But back in my early days, it was a terrible disease. Why? We didn't have viral agents, and we didn't know how to use corticosteroids. So these people suffered greatly, but once we developed those agencies, that kind of went away. Now, the 1980s come along, and we have a disease called AIDS. Now, HIV patients had a lot of neuropathies, a lot of migraines, a lot of intractable pain. And so we treated that. And that virus, as far as the pain went, behaved a lot like the polio virus or like the post-herpetic virus. And then we go into the 1990s. And then we start having a lot of doctors saying, you know, there's a disease out there called fibromyalgia. And we think it may be caused by a virus. Now, I'm not going to go into my first experiences with fibromyalgia, but I came to the opinion that about the turn of the century, that viruses had a lot to do with intractable pain. And I thought so for two reasons. Number one, people had today what I like to call multi-site migratory pain. and they had fibromyalgia one day, TMJ the next day, leg pain the next day, pudendal neuropathies the next day, and the pain floated around. And so I said, the only thing that can do that is a virus. It has to be an infection. And guess what? They thought that back in the 1800s, and they called it autoinfection. So my observation is not new. The second thing that made us wonder about viruses is that you took two people who had similar injuries. They both fell off a ladder. They both had epidurals. They both delivered babies, but one got severe intractable pain and one didn't. Why? We had no explanation. No explanation. But I felt that there must be some viruses involved. So believe it or not, I've been taking viral tests on intractable pain patients now for about 20 years. About 20 years. Now, I'd run into a roadblock. About 3 or 4 years ago, I didn't know what to think about the viruses. I had a lot of tests. I've written some papers about it. Nobody paid attention, incidentally. In fact, I presented posters on this at pain meetings, and I coined the term the lonely poster. Nobody came to see them. But at any rate, I've got a lot of data on viruses, but it was very confusing because I would find patients who had blood test positive for the Coxsackie, herpes, cytomegalovirus, all kinds of viruses. Rubella was a big one. And obviously HIV, not HIV, but EBV, Epstein-Barr. Well, here's what happened. About 4 or 5 years ago, study number 1 came out of the University of Cincinnati showing that the Epstein-Barr virus would activate the genes that produce rheumatoid arthritis, systemic lupus, Sjogren's, multiple sclerosis, type 1 diabetes. So I said, oh my gosh, that virus does that. It's the only one we know that does that. I better saddle up and start studying this more. Within a few months, the military came out and showed a big study of about 955 military recruits who had negative serum for Epstein-Barr, but they call it multiple sclerosis, and after that, the serum was positive. But then the kicker comes. Then two things come along that really is why I'm here tonight giving this talk. Number one was a study showing that the Epstein-Barr virus would activate the glial cells in the brain and the spinal cord. And we've known for years that activation of that cell causes the neuroinflammation that knocks out your receptors and converts your pain from intermittent and once in a while to constant. Okay, we talked about that last time, glial cell activation and neuroinflammation. And then here comes the fourth study in a short period of about 3 years. Some bright research found that the Epstein-Barr virus did produce what's called an autoantibody. Okay? Now, technically, for those of you who are scientifically oriented, the Epstein-Barr virus would reactivate, enter something called a plasma cell, and the autoantibody was formed. And then what's an autoantibody? Here's a big part of your lecture tonight. In fact, all of you are going to really have to know about autoantibodies or what it means. An autoantibody means that the antibody isn't attacking the streptococcus or the Lyme disease or COVID that's coming from the outside. Auto means it's attacking you inside the body. Okay. In other words, definition of autoimmune is it's a process in whereby your own tissues are being attacked, destroyed, degenerated, and causing pain. Okay? So anytime you hear the word autoantibody, you want to be thinking pain, because a lot of you out there who are suffering pain, probably most of you have autoantibodies floating around your blood right now as you hear this. Okay? All right. Now we're going to take that, and what I've done now in the last 3 or 4 years, and I know there hasn't been a single day I haven't dug into everything I can read. I've now collected hard blood data on about 150 people who have either arachnoiditis or another severe pain condition. We've analyzed all kind of data. I pulled out all my old tests to go back 2 decades. And so we put together a lot of things, and I do have a book coming out on this here in a few days. So that'll be good. You can put all this together, but we're going to cover everything in the book, and part of it here tonight. Okay, now we're going to go back to the beginning about what's called the Epstein-Barr virus. I want to show you a picture of a man. Okay. Now, I doubt that anybody out there knows who this is or knows that he's only got one eye. Okay. This man is Dr. Dennis Burkitt. Now, who was Dr. Burkitt? Well, in the craziest sort of ways, we wouldn't be having this program tonight if it hadn't been for Adolf Hitler. Now, Adolf Hitler in the 30s and 40s, he and his Nazis wanted to rule the world and exterminate all the Jews. Okay? Well, Dr. Burkitt was a young military medical officer in Britain, and he joined the British Medical Corps, and he was assigned by the British Medical Corps to Africa. Okay? Now, it turns out that Dr. Burkitt, Dr. Ibsen and I would relate to him because he wanted to be a missionary or a minister, and he was like your two doctor hosts here. We're probably more minister than we are doctor, but so is Dr. Burkitt. Anyway, Dr. Burkitt, when he was in Africa, he became very concerned about the poor medical care they had and about the travesty of the children and of the indigenous population. So after the war, he decided he wanted to spend the rest of his life staying in Africa as a civilian, taking care of these children, and that's what he did. Okay? Now, what he did is he was in Uganda, and he was the only surgeon there, and he called himself a bush surgeon. And he was looking after these thousands of kids and what have you. And he started running across children with tumors of their body, mainly of their face. Here's the first one. We're going to take a look at this. Okay. Here's one here in which the tumor is eating away his face. Now, what I want you to know as you look at these pictures, and I hate to put it this way, if this virus can eat those children's face away, what can it do to your intervertebral discs, or your arachnoid membrane, or your pudendal nerves? Don't think it can't do all of these things to you, okay? It didn't just hit the face. These tumors, there's a young boy with tumors in his scrotum. Another child, tumor of his leg. And a young girl, tumors of her breast. Now, when Dr. Burkitt saw these things, he called them a sarcoma. They didn't know what they were really, but he did one thing. He went back to London and presented his findings there in a lecture in London. And you had a very, very bright pathologist by the name of Epstein hear his lecture. Here's a picture of Dr. Epstein. Dr. Epstein managed to raise a little money, go to Uganda, and arrange for Dr. Burkitt to cut off some of those tumors and send it to him and his assistant, Yvonne Barr, and see if they could find a virus in it. And blow the hole, and I won't go into all the technical things except one thing. The techniques that he and Dr. Barr developed are the same ones used today to grow tumor cells in culture and to find viruses in tumors. That same techniques today. Now, they got a lot of awards for this, and rightfully so. Bottom line is, they found the virus in the tumors, and ever since it's been called the Epstein-Barr virus. Okay? Now, next week I'm going to talk about what they did after their discovery, because there's some other heroes involved with this story. All right. But that gives you the beginning. Now, what we're going to do to wrap up this educational lecture is cover a couple of real basics. First off, the Epstein-Barr virus is one of the herpes viruses. Technically, it's called herpes 4. There's herpes 1, 2, 3, 4, 5, and 6, and it's number 4. So it's a class of a virus. And what happens is this, without going into great details, 80% of adults on this planet come in contact with the Epstein-Barr virus in their first 2 years of life. And all those little babies there that get the sniffles or a cold, chances are that's the Epstein-Barr virus doing their first activation and entry into the human body. Now, the second group comes into the human body when you're a teenager or a young adult, usually having infectious mononucleosis. Bottom line is, by the time you're age 25, practically 95% of people on this planet have the Epstein-Barr virus, but it's no longer active. It goes into the body and becomes one of about 200 parasites inside the human body that we carry around every day. Now, a lot of those viruses are in the intestines, some are in our blood or saliva. The Epstein-Barr virus is normally carried in the membranes of your throat and in one of the lymphocytes known as the beta lymphocyte. Okay, so that's the beginning. Now, let me get into what's happened to people who are out there listening to this and get into the medical part. Under stress, anything that lowers your immune system, like a bad cold, delivery of a baby, falling off a ladder, epidural, psychological problems. If you do something that lowers your immune system, the Epstein-Barr virus is what we call opportunistic. It will do what we call reactivation. Okay, reactivation. Now that's another term that you're going to need to know. What does it mean? It means that the virus has gone from a quiet, harmless, latent or dormant state to an active state in which it's floating through the blood, it's causing autoantibodies, and it's entering your tissues and going to cause disease. Okay? Now, I'm going to shut this off because I want to sort of stop right here. When that virus reactivates, it has the ability to do terrible things, just like those pictures. Okay? It is now known today that it's the cause of anywhere from 2 to 4% of the world's cancers. Okay? It'll enter lymph nodes, it'll enter the gastric mucosa, it'll enter the throat membranes, and it will cause cancers. Okay? Because the virus will grow there and the autoantibodies will chew away the tissue. The second thing it does, it takes a normal person and converts a lot of normal people to having an autoimmune disease like rheumatoid arthritis, type 1 diabetes, Sjogren's syndrome, Hashimoto's, lupus, a lot of those diseases. But what we're finding out in our studies, it will activate the glial cells, it will cause destruction of your arachnoid membrane, your small fiber nerves, and it can give you every one of the painful conditions that we talk about on this show. Okay. Now, let me make sure you know that there are some other viruses that are secondary. It's sort of like they're the junior viruses to the Epstein-Barr virus. Might talk about that later. But what I want you to know is that the virus normally is there. It can do what we call reactivate, and it can cause these diseases. Now, what do we do about it? Turns out, I want to give you some good news, and then we're going to have to shut up. The good news is that a lot of the things that we're doing right now for treatment suppress the Epstein-Barr virus. We didn't know this. But for example, plain old vitamin C, your collagen, your peptides, your anti-inflammatories, a lot of your vitamins, a lot of your herbal products actually keep the virus from reactivating. But we have a problem, and that's why I'm bringing this up, and I want everybody to learn about it. And incidentally, I hope some of you get interested and kind of become educators about Epstein-Barr virus. You not only have to keep it from reactivating, you've got to keep the inflammation down, and you're going to have to sort of reduce the viral load. You can't get rid of the virus because it's a natural parasite. That's why with rheumatoid arthritis, we've never been able to cure it, but we can control it. We can do the same thing with CRPS, with adhesive arachnoiditis, pudendal neuropathies. We can control these things. We probably can't get rid of that virus totally. So anyway, this is lesson one. You'll be hearing a lot about it because it does act as a catalyst. It is what we call a causative factor. It's not the cause, but it takes a problem and makes it worse. Let me put it that way. But the good news is we've got good measures to keep it under pretty good control. All right, with that, I want to call forward our guest tonight.
Before you do,
oh yeah, you bet, Mark.
just a quick question. So, opiates were free to use in the 1970s.
Yes.
Where was the opiate epidemic caused by those opiates in the 1970s?
Hey, we didn't have any opioids.
I know, right?
There was, you know, in the 1970s, I was, besides, I'll tell you how I got my pain clinic started. I was really more interested in addiction, and I had the methadone programs. And we had some people who had severe pain who couldn't get some help, so they went to the methadone clinic. And one day I had about 3 street addicts come calling on me. Now, anybody who's half a doctor at all knows how to tell the difference between a hardcore addict and a pain patient. And I had these addicts come to me and says, Doc, we need to talk to you. There are some people in the line getting their methadone and they're not addicts. What are they doing here? I said, what do you mean they're not addicts? He said, oh, no, they're not addicts. They're nice people. He said, they're nice people. And I called him in, and I got one guy who was an 18-wheel truck driver. He had more things wrong with him. A couple were housewives, and I talked to him. He says, yeah, well, the doctors didn't know what to do about their pain, but we heard methadone helped pain, so we thought we'd come to the clinic. And in those days, it was friendly. Okay? And then you know who else brought me most of my patients? DEA, the Los Angeles County Sheriff, the Los Angeles County Department of Justice. They're the ones who got us to do the pain programs and the drug programs. They were partners. As a matter of fact, I was kind of a reluctant stand by. So remember, I've been through the days. Don't let anybody tell you that you got to have this attitude we have in government and in law enforcement today that pain patients and drug addicts are bad people. None of them are bad people. They all need help. And back in those days, I mean, they are the ones who got me to do this. We worked hand in hand. And I used to have the narcotic officers train in the clinic to learn how to examine eyes and look for needle marks and to recognize who's a pain patient and who isn't. Oh, I remember one time I had some DEA agents pick up a lady in Pasadena. She's about 70 years old. Well, she put on her lipstick and her best wardrobe, and the sheriff brought her over. And they said, Doc, would you take a look at this lady? She's using a lot of narcotics, but she isn't out on the street. Could you take it over? Well, we did. In fact, God, we used to take care of the addicts that worked undercover for the FBI. In other words, there was a time in this country when I truly believe that you could go to anybody in a government agency and you found care and love and concern there. Today, you hardly can talk to them. So anyway, we didn't have any epidemics, and we gave better care at that time than we do now. And I never had to look over my back or worry about anything. So things have changed. It's awful. Okay.
Well, it makes you wonder if it was the lipstick.
There you go.
We should ban it.
This lady would hardly let him go. She was having more fun all day, and so were the sheriff's pages. Yeah, she was quite a character. Yeah. So
okay, sorry about that diversion.
Yeah, there's
my apologies.
Times, and I've had great care stories, to be honest about it. I hope we can bring them back. Let's hope. Anyway, is Denise out there? You're there. All right. Can you hear us all right? What have you?
Yes.
Okay, very good. All right. Denise, we've been trying to get you on here for some time here now. Now, we're going to start with a couple of basics, and Rhonda's here. I know you've been having a lot of correspondence with her, and you know Mark. First thing that people want to know about you, particularly because you've had a little fame and you're well known. Where did you come from? Where were you born? Where were you raised? Tell us something about who you are. Where'd you come from?
Well, I like to say that I'm a gal of the globe. I was born in Virginia, but it was pretty much a drive-by birth. My my father was in the petrochemical industry, and he traveled to various locations to work when we children were younger. And so we were living all over the place, from North Carolina, South Carolina, Washington, Georgia, Maryland, Mississippi, and we finally settled in Texas when I was about 12 or 13 years old, for the most part.
12 or 13 years. Okay. Now, were you sick at those years?
Was I sick? I didn't know if I was. Typical children illnesses. I did have shingles. When you mentioned that, that made me think twice, because I had not thought about that with regard to Epstein-Barr. But I did have shingles and measles and all those typical childhood issues. I'm going to be 64 years old in November, so we still had those issues in those days.
Sure. Uh-huh. Okay, so you're in Texas. Did you finish school there? And then, okay, and then how did you get into entertainment?
Well, I didn't originally start in entertainment. I started in the beauty industry. I worked as a cosmetologist for a few years, and I was what they call discovered by another salon that we were doing a hair show with in New York, who was very involved in the fashion industry. And I decided to come to New York to start working as a model, and that's how I first became involved in it.
Uh-huh. Okay. And about how old were you then?
I started late in life, according to the industry. I was 21, I think, or 22, which isn't old by anybody else's standards, but in that industry it is, or was.
Uh-huh. All right. Then tell us, and you take your pick. You got to Los Angeles somehow,
I did.
and you got sick somehow. Which one you want to talk about?
Went to Los Angeles on an airplane in 1992, and I did that via London, where I had been living for the previous 10 years and working. I was living and working in Europe for about a decade and traveling all over the world. I saw someone ask or make a statement about being in Kenya and getting sick, and I've been in Asia and all kinds of places and been sick in those places too. So you never know where you're going to pick something up. But I lived and worked all over the world, but I came here via London.
Were you in the beauty business at that time?
No, I was in fashion.
In fashion at that time. Okay. All right. And then, so you got to Los Angeles about the same way? You just flew in one day and decided to stay, or how'd that happen?
Well, I flew in to see a boy I was interested in, and then I ended up staying. And that's how I came to be here. But if you're asking how did I originally become to have fibromyalgia and Ehlers-Danlos, I will tell you that as a child, I was like every typical child with that has Ehlers-Danlos, knowingly or not, very flexible. And we used to do things like Chinese splits and, have lots of sprained ankles and all the various things. And I used to have a lot of headaches as a child, lots of migraines, and I would feel like there was like a ice pick piercing my brain. I'd have tons of those. Well, that flexibility that I had turned into being able to put both in my head and put my arms through my legs and splay them out and be a human ball with a head and all of those things. And those were part. We had lots of fun, joking around about that. However, in 1987, I was in Egypt, and we were doing a world tour for Martini and Rossi, shooting a calendar. And it was 6 countries and 5 and 2 months per country. And Egypt was right in the middle of the shoot. And on my day off, my life boyfriend had come to visit me there because he had never been to Egypt before. And we decided to go horseback riding on that day off. Unfortunately, I had a horseback riding accident that I will say is probably worse than Christopher Reeves was. I just happened to fall better than he did. A 4-year-old black Arabian stallion flying across the desert. And it was a beautiful moment. I remember it like it was yesterday. The sun was setting. It was a beautiful, golden, balmy, sunset, and flying really fast on a horse that was probably way too big for me to be riding, because it was like driving a Ferrari of a horse. And we were about to go over a sand dune, and I did not want to go over the sand dune because I'd never learned to jump. So I started to rein him right, and he didn't want to go right. And I reined him again a little harder, and he didn't want to go. And the third time I reined him again, he bucked up, like you see Trigger doing in the little Western movies, that little horse thing, bucking up on his hind legs. And then he fell to his knees, threw me over his head. I went flying and smashed my face into the sand and rocks and broke my nose, my teeth, my ribs, and compacted my spine, and ended up going to the Meeser Hospital in Cairo to have emergency plastic surgery on my nose and to take care of everything. And the good folks that I was shooting the calendar for decided that because I was riding on my day off, that their insurance didn't need to cover me. So that I had to finish in that kind of condition. So I did. Needless to say, a few years later, and this is after I had moved to London, that was in 1987. And after I moved from London to Los Angeles in 92, I started having a lot of pain in my hip. And it turned out that I had bone-on-bone osteoarthritis with avascular necrosis. And I didn't have health insurance at the time. So I found this out through an x-ray I had from the free clinic going to Cedars-Sinai. And another incident happened long after that with a laser surgery on my face that resulted in a bad burn. I had to get out of the entertainment business because my face was badly burned, and I had to heal that. But I was working in the commodities business, and my boss at that time saw that I couldn't walk very well and I was in a lot of pain. And so he got health insurance for me. And I took that x-ray that I had from Cedars to my provider, and they looked at it and they made me wait for, I think, 7 or 8 years before they would send me to an orthopedic surgeon. And I was just really struggling with pain. But I don't know if it was good or not that I had to wait, because after I had the first hip replacement surgery, I started having hip dislocations. And I had, after the first hip replacement surgery, 8 years later, I had 8 hip dislocations. And so after the 8 happened, they decided to redo the hip replacement, and they did what they called a fusion of 2 types, and put a traditional component in my thigh that was not there before. It was a different, newer model with a larger head and a wider spigot that was in your bone to maintain the integrity of your femoral bone, because hip replacements happen every 15 years. And when you're under 50, they try to maintain the integrity of your femur. So they replaced the replacement, and I had another 10 dislocations. And what was really hard for me to handle was, while I was in the emergency room during those dislocations, I was accused of doing it on purpose to get drugs. What I didn't know was that I had Ehlers-Danlos. And the only reason, and I have you to thank for this, the only reason that I found out about it was watching YouTube videos with you talking to a women's group one day, and you were listing the symptoms of Ehlers-Danlos. And I said to myself, gosh, that sounds like me. Gosh, that sounds like me. And you went down this list of symptoms. And so I went to one of my pain management doctors and said, I need you to have me tested for this. And it turned out that I had that as well. So that explained the dislocations. But I had also been diagnosed in 2003 with fibromyalgia. And I just thought, before I had the Ehlers-Danlos diagnosis, I thought I had the worst case of fibromyalgia on the planet. I couldn't figure it out. But, the doctors were not very helpful. I just was treated like a woman who was hysterical and complaining about pain all the time and wanting drugs. And it was a horrible thing to experience, but it helped once I had the Ehlers-Danlos diagnosis. So I have you to thank for that.
You're welcome. Now, let me go back for just a minute. How old were you and what were your first symptoms of fibromyalgia?
In 2003, I was 33. My symptoms were I had unbelievable muscular pain, bone pain. I had really bad spasms. I would have my like a restless leg syndrome kind of thing, spasm, and my legs would spasm so badly. My knees would jerk up to my chest and it would hurt so much because they felt like they were turning inside out from my feet up. It was just horrible. I had migraine headaches and just I was sick at my stomach all the time. I had IBS, all the typical syndrome symptoms of the syndrome. Sorry.
Yes, sir. On the fibromyalgia, was it mainly on your trunk or legs or just all over?
It's all over with me. It's all over my body. I have it in my neck, my shoulders. I have spasms that happen in my abdomen that make no sense sometimes. I have one that happens in my back that feels like it's my heart. I get them in my legs. I get them in my feet. I get them in my hands.
Now, do you still have those?
I do, yeah, but I take medication for them, so that helps a bit.
Now, have you developed spine disease also?
I'm sorry?
Have you developed any spinal diseases also?
Oh, yeah. I have 5 compressed discs in my spine, and I have I'd have to pull up the MRI results, but I have like the the spondylosis thing. I've got the compressed discs. I believe I'm developing the cauda equina syndrome as well, and there's evidence of those in MRIs that I've had from a few years ago, and I'm about to take a test for another one because of an incident that happened 2 weeks ago with the chiropractor.
Well, I guess you better tell us about that one.
Well, I've had 4 hip replacements in my left hip alone, and the third and fourth one happened in the last few years because of an accident that I had in my storage facility where my foot got caught between the freight elevator and the floor because it was not aligned properly. There was a man-operated freight elevator and I had to run back to my unit. They were closing, so I was being rushed and my foot got caught between the elevator and the floor and it just flew me over. And I landed on the hip that had had the 2 hip replacements, and then it fractured my acetabulum. And I had to have a third replacement, and then that one failed. I had 5 more dislocations, and then they also had there was a liner on my hip replacement because from the third surgery, because I also was struggling with metal toxicity, with cobalt and chromium toxicity from the titanium. And so they put a plastic liner on there during the third surgery. And then after the third surgery, because of the dislocations, the liner dissociated and traveled into my thigh. And so they had to fish that out and then redo that again. But they did the fourth one so tight. I've never had a dislocation since, thank God. But, it did. I'm crooked now, let's just say. Like I have a warped leg. My knee tips inward and my one leg is longer than the other and it throws my spine out of alignment and
Do your doctors now, as far as your working diagnosis, is it primarily Ehlers-Danlos syndrome?
Fibromyalgia, Ehlers-Danlos syndrome, myofascial pain disorder, and I've got about 25 others. I'd have to send you the chart. I don't know the names of all of them, but there's quite a few things there going on. Now, I've had a lot of surgeries, and the other surgery I wanted to mention too, because according to what I've learned during studies, if you have Ehlers-Danlos, it's not really advisable to take NSAIDs. And during the opiate crisis, they had taken all of my opiate medications away and put me on NSAIDs. And I had a Valentino syndrome peptic ulcer in the duodenum with a large perforation rupture, and I nearly died They said if I hadn't come in when I did, I would have died. They had to give me life-saving emergency surgery, and they had ascertained that it was a result of the NSAIDs that had happened. And so I don't know if that's accurate. I've read differently since then, but everything seems to have changed on most of the websites that discuss it. But, you know, opiates and NSAIDs and Ehlers-Danlos. So I don't know what the truth is. I'm not a doctor, obviously, but my understanding it was because they're not good for someone with a connective tissue disorder.
Well, let me echo that. The long-term NSAIDs in an intractable pain patient, whether you're Ehlers-Danlos or not, is just not something that hardly anybody should do. I mean, okay, the only one that you can take over time is ketorolac, and that has to be by injection, because that's really not an NSAID. They just call it that, but it's not really one.
What is it then? Because I have taken it and it is effective, but what is it if it's not an NSAID?
They call it that. It has some anti-inflammatory action, but it's all in the central nervous system. It's really more of a opioid and what they call an N-methyl deaspartate agonist than it is anything else. It has a lot of anti-inflammatory actions, but it's been mislabeled. Okay.
I think
But
some that tramadol was also not originally an opiate, was it? And now it is.
yes, it's got a lot of central activity too, and in some people it works very well. Okay, so you have to kind of go by one. But oral NSAIDs, other than very short-term use, I don't think they have any place in Ehlers-Danlos syndromes or arachnoiditis or RSD. I don't think they have a place. Yeah, because first off, they just don't do that much for you, and secondly, they've got a lot of complications. Okay, they're good for intermittent athletic pain, dental extractions, but not for long-term use, which you're going to have. Yeah, Mark might want to weigh in on that also.
My understanding now is that they're actually worse for you than opioids. Is that accurate?
Well, opioids, absolutely. Opioids, and this has been our gripe for some time. Low dose or even high dose opioids, and once they're stabilized and they have almost no complications in long term.
Right.
And let's, we're among friends here now. The reason why people don't like opioids is they work too darn well, and they keep people out of hospitals, keep you off the street, keep you well, keep you working. I mean, opioids have been the good Lord's blessing. Why do you think they're growing out there in the field? Okay, so opioids, yeah, they're got their problems, but not near as many as NSAIDs, for example. Yeah.
I don't think they have that many problems personally. I think the problems come from the people who abuse them, but I take them every day, and I wouldn't do the things I do if I didn't take them.
Right. What would you do if you couldn't get them?
Well, I really don't know. I can tell you when I wasn't having them and I was in the worst pain states in my life, I was actually actively researching physician-assisted suicide because it was that bad. Sleep, I'd had times where I couldn't sleep for as long as 11 days because the pain was so bad. And at that point, you're hallucinating and you're going out of your mind. There was one time I remember going into the emergency room and the doctor was talking to me and I couldn't comprehend what he was saying. My mind was so gone because of the lack of sleep and the intense pain that I was suffering from, that the words that would come out of his mouth and they would become like scrambled letters in the air. And then I could not comprehend what he was saying. And I would have to ask him to repeat what he was saying so many times. And I still could never understand to this day what he was saying at the time. It was that bad. And I just thought, this is no life, I'm just taking up space here. I'm wasting air, and I talked about it with my psychiatrist and I was very, very serious about it. Not that I'm a suicidal person. I'm not. Who wants to die? No, I don't. I want to live. And given the life that I've had, which has been magnificent in the past, why would I want to? You know, I want to continue to have that wonderful life, and it was gone. So
Now, how old are you now? You're 64, you said?
I'm going to be 64 this November.
64. Well, you've done something right.
Sorry.
Before you've done a few things right. Let me give you an interesting statistic. 10, say 10 years ago, or before we really started understanding Ehlers-Danlos and what to do about it, do you know that few people live past about age 48? That was about the maximal length of time. And Elvis Presley, family's a good example, probably. They had it in their family, and they all died in their 40s, but they were not unusual.
Tips.
Yeah. Anyway, Rhonda, are you here somewhere? I know you guys have been having some conversations, and you both have managed to survive. And are you there, Rhonda? Well, I don't hear her. Anyway.
Do you hear me, Do you hear me,
There
Dr.
you
Tennant?
Oh, I can now. Yeah,
There you are.
Okay.
yeah.
Yeah.
Rhonda,
Okay.
you guys have been having some conversations, and you're both have made it, and come from at least the same disease background.
Same part of the world too. We're about 2 towns over in Texas.
Oh my gosh.
Rhonda, have you got some questions or comments about our guest here?
Hey, baby girl.
And can you hear me?
Yes, ma'am.
Ah,
Yep. Hear and see you great. You still there, Rhonda? Oh, you're muted, hon.
He's muted.
It's okay.
okay. All
There
right.
you
Am
go.
I unmuted now?
You are perfect now.
Can I just first say to everybody that this woman is such an amazing woman? Rhonda, I was having such a terrible day yesterday, and I have her to thank for getting me through it. This
Yes.
beautiful soul is like warm butter, honey, and maple syrup all together when she talks to you. It's so soothing. She just oozes warmth all over you, and I just love her. The short time that I've known her, I've grown to love her because of it. And I just want to say thank you, Rhonda.
You're good.
Am I okay? I'm here.
There you go.
Denise, you're very welcome. Just my pleasure. That was very sweet and very kind of you to say that. But
True.
it's my pleasure to help you through a difficult day. We've all been there. We all know what the depths of this disease can do. And Denise, you've got an amazing spirit.
Thank you.
Beautiful, uplifting attitude. I've enjoyed getting to know you and hearing about your very lengthy history. It's just been one thing after the next. And my God, I don't know how you've done it. How have you done it? Tell us how have you done it?
You know, I just try to stay positive. I'd like to say that I try to remind myself and stay militant in my thinking that it can only get better if I try. And if I try to think positive thoughts, if I try to, like you do, help other people. And then for a little moment of comedy, I have a couple of tools that I use to help me feel better when I don't feel well. This is one of them, and I suggest every lady do this too.
Okay.
I have a collection of tiaras to remind myself that I'm a princess or a queen, whichever you prefer. That always gives me a giggle and helps lift my spirits. So when I feel bad, I'll put
There
on
you
the
go.
tiara and try to dance around the room, you know. But
There you go.
on eBay, ladies. So just go get yourself a tiara. It'll screw you up to no good end, make everybody think you're crazy, which is always fun. But
That is
I pray
fun.
a lot. I'm a big God girl, and I am a big believer in gratitude, and so I always try to remind myself to be grateful and that there are other people in the world going through so much more than I'll ever go through, and that have had so much less. And so I always try to remember that, and I try not to indulge in feeling sorry for myself,
Yeah.
except when I have you on the phone. which I obviously did yesterday, but it was a particularly bad day yesterday. But, you know, trying to put others before you, not that you don't deserve, you know, attention or help. We all do, but it feels good for me anyway to do nice things for others and to practice random acts of kindness. I do that a lot, you know, so that helps me.
You can hear me. Is Dr. Ebsen there?
Yeah,
And
I'm,
yes,
I'm,
good.
I'm here.
yes.
I'm here, and I am very grateful to Denise to endorse the policy of militancy.
Yeah,
I got that going on. Thank you.
it's important. You have to,
We,
militant, and you have to just tell yourself when you're in your bad days, you will feel better. If it's 60 seconds, if it's 60 minutes, if it's, you know, 60 hours, you will feel better. You just have to remember that and then find something to do to help you get there, or someone to help you get there.
I'm in a program where the distinction is gratitude is the antidote to self-pity.
Exactly.
And that a lot of us who hurt, as soon as you start hurting, you start lurking in these negative spaces in your head and engage in thinking, and it makes it worse, not better. So I think what you've nailed is the core principle for those of us in pain is to find something or a list of things to be grateful for.
Turn
So
that
thank you.
upside down. I like to say.
Right? Yeah.
Mark, since we have you on there, we don't have a lot of time left, but could we, Denise, thank you so much. We're going to let, Mark's got a couple of things that we want to get out tonight. Mark, are you there?
I'm here.
Give us the report on the young lady in Maine. And then if we have a couple of minutes, I have a couple of specific questions for you.
I have a patient in Maine who I've been caring for about a year. She went through 3 doctors in Maine. She takes a lot of pain medication, and she's had a lot of catastrophic stuff. One of the catastrophes was 2 weeks ago. She was told that her pharmacy would no longer fill her prescriptions. And we've been studying the idea of getting an injunction or some way it seemed to me that when she got that deadline, she became a death row patient. And I wanted to approach this as if we could appeal to the government or to the governor of Maine for a stay of execution, essentially. I loved the idea. I thought it was brilliant. That's not, most of my ideas are, 80% are. And we lined up an attorney, John Flannery, and he's been looking at it as the potential case. But the problem about getting the legal system moving is it doesn't respond rapidly or in time for Brandy. So just so you know, she has another week's worth of medicine, and this is the way it's been for a year. She finds somebody to fill a prescription out of compassion. Some other pharmacist at the same pharmacy hangs up on me when I call the prescription in. So she's got another week. She's going to get another week. She did appeal to she filed a complaint with the Maine Human Rights Commission. And I thought that was a positive thing until she told me today that the Human Rights Commission can take as long as 2 years to make a ruling. Well, she doesn't have 2 years. She has 2 days. So we're scrambling to find a way to find who can treat people and fulfill the commitment that the CDC opioid rapid response team claims that they have, that they'll help people. And so far, I'm sure there are others helping that are stealth, but so far, I'm the only one I know of that's doing that. And they're not doing it. So we have some legal options, some political options, some practical options. We're doing all of those things. And each time we make some sort of unprecedented idea, it seems radical for her to file a lawsuit. But on the other hand, it seems radical to let someone die a painful, agonizing death due to abandonment. And so that's where we stand with Brandy. And Brandy kind of, I'm calling her our Erin Brockovich. So she's, she's committed to not only helping herself stay alive, but help the rest of us make the kind of narrative breakthrough that's necessary in our culture, so our citizens are not cheering when we're suffering. That's all.
Mark, you and I discussed earlier today that it's around as you go around the country, you see some states that are doing a good job of treating people. Yeah, and now we've had 2 or 3 new developments that might want to make a preliminary comment now, but I'd like to, for next week, one subject I'd like to discuss is we have some areas in the country in which there's a big push to put everybody who needs an opioid on buprenorphine. Okay? In other words, that's right. We have some other places in the country in which major prestigious institutions are just walking in and one day and saying, our doctors will no longer prescribe any opioids to anybody for any reason. And we have some of that going on. We need to have sort of a strategy that might have to fit different places. But I'm asking you and I'm asking everybody else this week to think about what are we going to do and what practically and from an advocacy point of view. And I've been afraid of this thing to where doctors are now employees. So the employer walks in one day and says, you doctors can no longer prescribe opioids. It's here in some places. You have a closing comment.
Yes. Your doctor doesn't work for you anymore. That is for sure true. And what that means is you've got to work for you. And every patient I know in these circumstances needs an advocate, preferably male, in the exam room with them, and an attorney, and to leave breadcrumbs for your loved ones to file wrongful death cases against the people that are perpetrating this. The main perpetration, of course, is the collapse of addiction and addiction medicine with pain medicine. Buprenorphine, I think, might be a pretty good drug for addicts. It's great for withdrawal, and it's lousy for pain relief. I've only seen 5% of my patients get any pain relief from buprenorphine at all. But since the people that are dispensing it and pushing it think that we're addicts and can't make the distinction between a pain patient and an addict, they're gonna insist that we use an addiction medicine like buprenorphine for our pain, but it doesn't work for that. I just had a patient, and I'm reminded of it, is one of my patients was going to a pain specialist in Billings, Montana. He retired. They hired a new guy. The new guy comes in, and this is a pain medicine trained guy, and he puts the patient on Suboxone while they were still on opiates. Now, the idiocy of that and the harm of that is kind of crazy making. So we'll get into that in detail next week. But yeah, I think we got to really address that.
All right. Well, thank you so much. Thank you, Denise. Glad you're with us. You gave a nice, caring presentation. I really appreciate it. Rhonda, thank you so much. Jamie, as always, you're our hostess with the mostest, and we appreciate what you're doing. We'll sign off tonight. We'll see you all next week. Good night.
Thank you, Dr. Tennant.
So very much. Dr. Norm
Jamie,
did have.
I see that Dr. Norm is there to say something. I'll stay on.
I was saying Dr. Norm had something he wants to add.
Well, I think what's missing out of this discussion, I'm going to go back to where we were using the word opioid. Because when I came out of school, opioids was something entirely different, and that there were synthetics. So we referred to them as narcotic analgesics and stuff. So that, I haven't heard that word mentioned anywhere in this discussion. But I want to go back to something that was very interesting. I stumbled across it in a conversation, and a person I met was where we get this term opioid. The opioid term itself was developed actually by a pharmacist who worked for the DEA, and some people know him, who wanted to be an FBI agent, but he couldn't, and he failed. So then Joe Ranasuzi. What so Ranasuzi does, he manipulates this term opioid and turns it into a pejorative. And here's where we are today. If you go back and look at the Libby report that we have, we even have morphine and codeine are opioids. In fact, they're not. They're opiates. opioids
Yeah.
are your synthetic products that are getting that were derivatives of the phenanthrene ring. The other point I want to talk about is the use of Suboxone. That comes down with the androchylotiny kind of thing because it's all about money. The fight between that comes to the Sacklers and the folks who had investments with the Suboxone makers and those sort of things. So I see that as when people start recommending Suboxone, that is where we're now between this legal struggle between the two companies, the guys who made the OxyContin, and the guys who were invested like Colotny and Prop guys into Suboxone. So I'll just leave it over.
Thanks,
Very
Norm.
good. Very good. Thank you, Doc.
Great
Thanks so
work.
much.
Was Joe Anasuzi in the 60 Minutes?
Well, Joe Ranasuzi, yeah. Joe Ranasuzi,
Yeah.
interesting. I debated Joe Ranasuzi. We were at the National Dental Association meeting, and he was his pharmacology pharmacology was all off. And in fact, it was off because he was then saying something like gabapentin was so dangerous and all sort of thing. And the other thing is that it seemed that he wanted to be he said that doctors, again, if you go look at the Libby report, they were getting ready to get rid of the DEA, and their numbers were bad, and so they needed to explore a different avenue in order to get some results. And of course, Ranasuzi comes along and says, well, physicians and pharmacists, they dispense narcotics. We'll call that opioids, and then we'll go from there. And it was all about, if you look at the Liddy report, it was all about the mission failure of the Drug Enforcement Agency. And what the Liddy chief says, we go where the money is, and the guns aren't. We get all that stuff, getting all this stuff happening at the same time. And it just ballooned and ballooned and ballooned. Now, this is about acid forfeit. It's not about, and we've turned the word opioid into a pejorative. The issue here, and I see it, is we still haven't, what people are failing to present on news media is pain, and pain is real. And one of the failures of news, I want you to know something very peculiar that I've noticed, okay? You look at, if you go to a morning show, the morning shows, particularly on radio, and you look at the nature of the host, and I looked like for the first morning from 6 o'clock to 12 in the afternoon. If you look at the nature of the host, you'll find that most of them are comedians, all right? And what I've noticed is that what the DEA, what these guys, law enforcement, very effectively at producing their media or distorting their false narrative, they use these guys who are famous comedians. Look, Bill Maher, for example. I mean, he's a guy, man. Oh man, but Bill Maher is totally distorted. John Fugelsang is another one. Greg Carr. These are all comedians, but they have major market shows, talk shows in the community, and their word means more than Mark Ipsen ever will have in his training. Mark Ipsen could never get past a Bill Maher. I mean, Bill Maher says, oh, well, doctors have killed thousands and thousands and thousands of patients, stuff like that. It's rubbish. It's absolute rubbish. All right, so I don't want to scare anybody any more than what I am. So
Thank you.
I just thought that's my observation. Thank you.
Thank you.
So much. Denise, we so appreciate your time being
Thanks
with
again,
us tonight.
Denise.
Thanks
Thank
so much
you.
for everyone that's been all through this with us. Thank you, Dr. Ibsen, Dr. Tennant, and thank you, God, for being with us. And until next week, please stay alive and remember you're not alone. We're looking forward to another good show. Thanks again. Take care.
Mark, read the message.
Thank you.
Okay.
God save the pain warriors.